Thank you, Brian. By the way, because we are very limited time-wise with 4 presentations, I would like to ask the speakers to hold off asking any questions or making any comments until the very end of all presentations. As it turns out, we don't have anything else happening immediately at 1 o'clock in this hall, so if any of you would like to hang around and ask any questions or have any discussions with us, we'll be happy to stay a little longer and address any of your questions. So without any further ado, I'd like to move on by presenting to you in very brief outline and in somewhat more detail than my introductory remarks, the concept of neuroprogression. So as I said a few minutes ago, neuroprogression basically connotes the chronic, relapsing, reoccurring course of psychiatric illnesses, not unlike many medical illnesses. At this point in time, we do not have a cure for psychiatric disorders. That's well known. However, we can do much, much better in terms of making more accurate, personalized diagnoses and more accurate, personalized treatment plans with the hope of arresting the neuroprogressive course of psychiatric disorders. Many factors contribute to the neuroprogressive course of psychiatric illnesses. You'll see them here. They include neuroinflammation as part of an overall pro-inflammatory state in the whole body, because the immune system exists both in the periphery and in the brain, and the immune system is upregulated in conditions, medical conditions, psychiatric conditions, and summarily in anything that's stress-related. Oxidative stress is something that we will not have time to get into in any detail today. Mitochondrial dysfunction has also been identified with ER dysfunction as being contributory factors. And last but certainly not least, in the rather lengthy list of components contributing to neuroprogressive course is the interference with the ability of the body, mainly the brain, to produce neurotrophic substances, or otherwise referred to as growth factors. If anybody is interested in delving deeper into the topic of neuroprogression, I'd like to present to you a volume that my colleague Professor Leonard and I co-edited. It came out a couple of years ago. It's available most in any bookstore, including Amazon, if you would like to purchase it. The concept of sensitization is actually not a new concept, but I'd like to refresh your memory about it. An inherent vulnerability or stress susceptibility or stress vulnerability is a condition that we have to keep in mind. We are all exposed to stress, but some of us are more sensitive to stress than others. And if we are more sensitive to stress, we become more easily sensitized to stress. Each subsequent stress-related episode increases and intensifies sensitization along the lines of the well-known kindling effect. Drug abuse, such as cocaine, contributes to this sensitization with untoward consequences. And each type of sensitization contributes to faster illness stage progression and greater illness duration, and of course treatment resistance. Up, go this way. There is a high medical burden in psychiatric disorders, with each increasing episode, whether it's a psychotic episode, a depressive episode, a bipolar episode. the comorbidity chances increase exponentially with the number of episodes, as you see depicted here. The medical comorbidity is actually well known in psychiatric disorders, especially depression and cardiovascular disease. This is a study from the Swiss population, and again you can see that unipolar and bipolar depression are associated with premature mortality, as you can see in this slide. The role of glia, neuroglia, is very important. We are increasingly recognizing the importance of glia and the participation of microglia cells and, in general, glia cells in the course of neuroprogressive consequences. As you see here, when neuroinflammation has set in, there are many facets of dysfunctionality, including oligodendrocytes, transient demyelinization, neuroinflammation of microglia, neuronal consequences, astrocyte dysfunction, changes in capillary permeability, disruption in the blood-brain barrier, which becomes, as we call it, leaky air, thereby allowing penetration into the brain parenchyma of peripherally released pro-inflammatory substances known as cytokines, and so on and so forth. I'm sure you're familiar with the concept of allostasis and allostatic load that was coined many years ago by Bruce McCune. Basically, what the concept of allostasis and allostatic load connotes is that with each successive episode, whether it's medical illness or psychiatric illness, and episodes of substance abuse, and any stressors in life, the allostatic load increases, leading to inflammatory changes, disruption in autonomic nervous system homeostasis, and so on and so forth. The course of illness is heterogeneous in mood disorders, but on average, the risk of recurrence increases with the number of prior affective episodes. Increasing the number of affective episodes is associated with risk of reoccurrence, increased duration of episodes, higher intensity of symptomatic severity, and risk of developing ultimately dementia that Professor Leonard may have time to address in somewhat greater depth and detail. Additionally, there are volumetric changes in the brain with loss of brain substance, differential response to pharmacotherapy, generally with a reduction in response to conventional psychopharmacologic interventions, differential responses to psychotherapy, progressive cognitive impairment, and overall progressive functional impairment. So we're going to address in this talk right now, as well as in the following 3 talks, ways that are available to us now and ways that we're in the process of developing in clinical research operations. How do we arrest neuroprogression and switch from neuroprogression to neuroprotection and early intervention? Using bipolar disorder as an example, because it lends itself very nicely given the fact that we know bipolar disorder, perhaps more so than most any other psychiatric condition, is very well known to have multiple reoccurrences throughout the lifetime. So an early intervention may interrupt the disease cascade. Lithium remains a treatment of first choice, but not the only one. As I alluded to, the immune system plays a major role in stress and stress-related disorders, of which major depression and bipolar disorder afflict a very high percentage of the population. Depending on what statistics you read, that percentage, the prevalence, lifetime prevalence, can be anywhere between 10 and 15 or 18%. I want to draw your attention to this enzyme here, cyclooxygenase 2, it's a rather complicated pathway. I don't want to belabor the point. I'm going to be talking a little more about COX-2 or cyclooxygenase 2. It's a critical enzymatic step in the whole and very complex pathway of neuroinflammation. I'm going to skip over these in the interest of time and draw your attention to the potential therapeutic utility of non-steroidal anti-inflammatories in depression. There are two key subtypes of COX, 1 and 2. The well-known aspirin is predominantly a ligand at the COX-1 and can have serious consequences in terms of bleeding diathesis, so we don't want to use aspirin to inhibit COX. We have better and more specific COX-2 inhibitors, such as celecoxib, which at this point in time, at least in the United States, is the only specific COX-2 inhibitors that appears to be safe to use even in higher doses and even over prolonged periods of time, unless there is a pre-existing underlying cardiovascular condition. Over the years, there have been a number of studies, probably close to 20 to date, from different parts of the world, all over the world, where clinician investigators have chosen COX-2 inhibitors, such as celecoxib, which I'm sure is available in Turkey as well because it's available all over the world, to modulate the activity of the immune system in the hope that by attenuating the pro-inflammatory state that is known to occur in many psychiatric conditions, perhaps in almost all of them, including psychosis, including schizophrenia, and neuropsychiatric conditions, including dementia, Alzheimer's type, and otherwise MS, and so on and so forth, in an effort to at least modulate the immune system and attenuate the pro-inflammatory state. Why is that important? There is a very plausible theory that attenuating the immune system's hyperactivity. We don't want to eliminate the immune system. We couldn't survive. We want to attenuate it and modulate it so that it returns to its normal operating range. So these are the studies that have been published where NSAIDs have been used with overall pretty impressive success. I want to show you in the remaining few minutes of my time a study that I concluded about 2 years ago in treatment-resistant bipolar depression, in which I had hypothesized that using celecoxib, the specific COX-2 inhibitor, in conjunction with a typical serotonin reuptake inhibitor, that being escitalopram, would A, reverse treatment resistance in bipolar depression, B, augment the outcome, and C, accelerate the onset of antidepressant and maybe even anti-anxiety response. Again, I'll skip over the design of the study and get straight to the outcome. So this was a double-blind, randomized, placebo-controlled study. Basically, half of the patients were randomized on a double-blind basis to receive either escitalopram and placebo or escitalopram and celecoxib. The patients were followed very closely for 8 weeks, and you can see here the difference in response rates between those who received the combination of escitalopram with placebo versus those who received the combination with celecoxib. So the response rate with placebo was 45%, which is probably higher than expected, although not so surprising, but the combination with celecoxib gave us a highly significantly better response rate. The flip side to this is that the no response rate went down significantly from 55% in the placebo arm of the study to 22% in the celecoxib arm of the study. And the correlation, the p-value was 0.02, which is statistically significant. We also looked at remission, and much to our very, very pleasant surprise, the remission rate on the placebo arm was 10%, no surprise here, but 63%, about 6 times as high in the combination with the COX-2 inhibitor. The flip side to that is that no remission, 90% in the placebo arm, 37% in the celecoxib arm. So we still don't have the perfect answer by using a COX-2 inhibitor. However, these were only 8 weeks of treatment, and we have all these very impressive and encouraging results. And I suspect if the study had extended beyond 8 weeks, we might have gotten even better results. You can see here the difference and the statistical significance. At week 8, using the Hamilton D17 rating scale, the difference between the placebo arm and the celecoxib arm was p equal 0.002, highly significant. This is the time course of the 2 arms of the study, again statistically significant. We talked about that. That was also a major surprise. After 1 week on the combination, we saw a statistically significant improvement in depression. After 1 week, that usually doesn't happen. Also, anxiety went down in 1 week. Again, statistically significant. The pro-inflammatory status is well known. We confirmed that. You see here the key cytokines, IL-2, 4, 8, 1 beta, and TNF-alpha are all pretty much, except for interleukin, well, no, they're all statistically significant between healthy controls and the patients, the bipolar, depressed, treatment-resistant patients. Don't have time to show you in detail, but we did look at some key pro-inflammatory cytokines, such as interleukin-1 beta. We wanted to see if we can find any statistically significant correlations between clinical improvement and reduction in the pro-inflammatory state. And the answer was yes, we did. Interleukin-1 beta stood out. It approached statistical significance. CRP, however, and you'll hear more about CRP in a little bit. Yes, CRP also by week 8 decreased only in the celecoxib arm, and the p-value was highly significant. So, in conclusion, so that the other speakers will also have their allotted time to present to you, I would like to submit to you that the approach we're taking to include inflammation in our investigative armamentarium, and hopefully sooner rather than later, we'll be able to use routinely at least one pro-inflammatory biomarker, that being CRP. You'll hear more about CRP from Dr. Prohaska, so I don't want to steal her thunder, so to speak. But this is actually a very promising endeavor, along with other cytokines as specific pro-inflammatory biomarkers. There are others in the making. Last but not least, introducing the last speaker and shifting gears a little bit, we're going to also address the issue of pharmacogenomics as a very promising approach toward the goal of reducing non-response, reducing neuroprogression,